individually. I cannot give you an intelligent answer just like that.
Okay. The next question is, I'm in stage 2 lipedema, lymphedema. What can I do for pain? I'm already on keto and weight is normal. Is there any advice you can give her?
She has, I didn't, can you repeat? Speak just a little bit slower, Larry. She has lipo and lymphedema. She's already what?
Lipolymphedema stage 2. What can I do for pain? I'm already on keto and weight is normal.
Your weight is normal?
Yes.
Well, first of all, for pain, many people use ibuprofen, and it has been shown that that can make it worse. And ketoprofen, like ketoprofen, supposed to be much better for lipedema, anti-inflammatory medication. Unfortunately, it's difficult to get in the US, and some you have to order it from Canadian pharmacy. And there's a certain mechanism how it affects the enzyme different than regular NSAID. Stage 2, I think, basically, I would suggest, I mean, it should be evaluated for liposuction, for lymph-sparing liposuction. I mean, if you optimize, look backwards. I mean, the process of thinking, the evaluation to decide if and when to have liposuction. I thought I tried to put it all in the slide of Cleopatra. I called it Cleopatra because I assume nobody in the attendee called her Cleopatra. So it's all there. If you feel that today your symptoms do not enable you to perform what you're supposed to perform in life, and if you optimize, apply and optimize all conservative treatment modalities, the next step is to try to do surgery. I don't see any other choice, because by definition, you cannot live normal life. That's the definition. So I think that's the next step.
Thank you. So the next question is, my fat doesn't hurt. Does it mean I do not have it? Maybe that goes to the diagnostics. What can you answer to that?
That your fat does not hurt? Is that the question?
Yes, the fat doesn't hurt. Does it mean I don't have it?
The difficult question, and Stephanie always tells me, Doug, not all lipedema patients have pain.
No.
But Stephanie, you can put your opinion there.
I mean, I agree. I don't think that everyone that has lipedema has mass amounts of pain. But again, without having a consultation and seeing the patient, the person that's asking the question, it's really difficult to determine, whether or not that person has lipedema. But it's not completely unheard of to have lipedema, but to not have pain as well.
I can also add that if, for example, you have very large pockets of fat at the inner thighs and the inner knee, and they really have very severe effect on your gait, mobility, ambulation, then I think they're coming to the category that Stephanie is talking about. And I think we may be able to save the knees by removing these large pockets of fat.
Mm-hmm.
I mean, we have seen really great results in terms of improvement of the knee pain in the knee joint after the procedure. And patients that were scheduled for knee replacement and they could hold off. What do you want to say, Stephanie?
No, I was just going to say that I agree with that. I mean, I experienced, a significant reduction in knee pain myself. So, yeah.
Thank you. One remark from our side, because that question comes up also here. If this webinar can be is recorded and can be watched afterwards, yes, that webinar is going to be recorded, and we can send you a link once you missed it. So the next question goes to Stephanie. Stephanie, the question here is: in what stage was your lipedema when you had your surgery?
I was a stage 2. I had
Stage 2.
stage 2 in 90% of my body.
Okay, then it goes also to you. Were your twins IVF? Wondering about medication's impact.
They were not. No, they were conceived naturally.
Okay, should we eliminate diarrhea? I don't know exactly what that here means, but this is a very short question. Any answer?
I don't understand the question. I'm sorry.
Okay, this is probably going to diet. If they could stop diet when they're going to do for a procedure, this is the interpretation I have, but not 100% sure. Then the next, it sounds like the doctor only does surgery on stage 1 and 2. What about stage 3 and 4?
No, actually, Doc, I don't think that's the case at all. Most of our patients are anywhere between a stage 2 and a stage 4. Absolutely.
Okay.
Yeah,
What about
I agree.
Medicare? Oh, I'm sorry, I'm not interrupting you. Go ahead.
No. I don't think we should punish somebody who would not get proper medical treatment, and unfortunately, she reached stage 4. At the same time, so I definitely will consult on stage 4. I would definitely do my best to improve her in terms of decongestion. Probably I'll prescribe for her the FlexiTouch. I probably will be very compulsive about improving her diet. That will help her. But when it comes to surgery, I think we have to be to apply good judgment, good common sense. I mean, because you cannot. There's so much you can remove in procedures. So probably in one procedure. So probably we'll start with the area that's most critical, most incapacitating, and that by itself can provide very significant improvement. And keep in mind, if you take this fat, for example, between the knees, between the thighs, only that, immediately if the patient can restore and start to ambulate more and can start to be more mobile, then she can start again to exercise, something she can do without that. If you start to exercise, then she will lose more weight. So it's a whole vicious cycle that we're turning around to the opposite direction. Instead of getting worse and worse, it should start to get better and better by intervention. But it has to be very carefully assessed and decide how to do that.
Thank you. The next question goes, have you done any patients on Medicare? What about Medicare is the question.
Medicare, yes, we have done. Unfortunately, they had to pay because Medicare does not recognize it so far as a medically necessary. But I know around the country, some women went back and appealed and demanded to be paid, and they got paid.
So can I interrupt just to make sure that you are understood, Doc? The patients that we have had with Medicare have ultimately ended up having to pay out of pocket for their own surgeries and had to submit for their own reimbursement. A big part of that issue too is Medicare, and you can correct me if I'm wrong, Doc, but Medicare doesn't really even have a pre-certification process. They sort of leave us in the situation of, if we participate with Medicare, to go ahead and do the procedure, but because liposuction isn't a covered code, I guess, they get denied anyway. So we end up in the position where, Dr. Shapira has rendered the service essentially, but not gotten any reimbursement. So unfortunately, until Medicare, gets on board, like we're trying so hard to get the rest of the insurance companies to do so, to recognize lipedema, that is the situation that those patients fall in right now.
Thank you. So the next question is, are you ever too old to be considered to have lipo procedures? Is there restriction in age?
No.
No, I think so, but just wanted that. So the next question, what if you have no support? You are nothing to have some, but some of us do not have support. No further, no whatever. If you don't have support, I don't know what this question belongs to. Let me go to that. I have had a large lipedema removed twice from my upper abdomen. My lipomas were encapsulated in the front sides about 80%. The back of the lipoma was ruptured, so it was very hard to remove it cleanly. Both surgical procedures were performed by open incision. Unfortunately, this is back bigger than ever, and it thinks that affecting things that it's pressing on, like my stomach. Is liposuction a possibility in this area of the body? That question, do you see the question? It's a long question.
I understand the question. Do you understand the question, Doc?
I think I do, but my answer is probably, let's consult on you and look at the specifics. What was done, what happened after, what you have now. Maybe there's a strong element of Derkum's disease that we have to address. It's kind of a little bit difficult.
Yeah, I mean, it sounds to me that this person would probably, stating that she had large lipomas that were encapsulated. I mean, that definitely does sound like a Derkum's quality. So I would agree that a consultation would probably be the best thing to do there.
Okay.
If you do liposuction after Derkum's disease, for Derkum's disease, the chance of recurrence is known to be significantly higher. Yeah.
So the next question, how long do the effects lasting? Once you have a liposuction, how long does it last?
There's the loaded question, right?
It is a loaded question. Well, the follow-up studies that are available from Germany, I believe they reported continuous improvement beyond the 10-year mark. But frankly, there are not too many studies, and because we don't have much experience. And I think a very important factor how long it will last is by changing of lifestyle. Changing of lifestyle is mandatory. I can tell you, anybody who listens, mandatory. That will make the results, the long-term results, so much different.
Can I interrupt and answer part of that question, if that's okay? As far as changing lifestyle, I do agree with Dr. Shapira on that, but we've also sort of stumbled across issues with hormonal fluctuations. So, because we don't know, again, the mechanism that causes lipedema in the first place, but we do know that it primarily, it affects women, and our estrogen hormones, we do run, always come into the question of, should I have my procedure, before menopause or after menopause? And those are things that we really just don't know the answer to at this time, because there are many women who will have their procedure prior to menopause, and then they go through menopause without any issues and they're fine. But then, you do always run the chance that, there might be a recurrence if you do hit another major hormonal shift, if that sort of happens too. So that's why we always like to, like Dr. Shapira said, to make sure that, that it is a lifestyle change. You want to make sure that, you're still, taking your proper supplements and wearing your compression if you need to, and, optimizing all of those, conservative treatments, even afterwards, so that, you can minimize the chance of a recurrence with the hormonal shift.
Thank you. Here's one question concerning before and after pictures. You certainly have, but probably not be able to showing now, maybe for one of the next webinars that we're going to do.
So Dr. Shapira and I have sort of decided collectively that we don't like to share before and after photos. And this is something that I touched on briefly in my presentation. Not because we don't want to show results or anything like that, but again, the stress is so much so that this is not a cosmetic procedure. Now, again, that does not mean that you won't, experience or gain some cosmetic results after your procedure, but it's not done primarily just for cosmetics. So, and that's kind of why I tried to touch on a little bit earlier as well is, so many of us, and speaking as a woman and someone that has lipedema, it's so easy to look at photos and compare yourself and your shape to someone else's, or you might see someone's, result that was really great, but then, you're left maybe disappointed because you feel like, you didn't get the great results that you saw in someone else's photos. And again, those things, everything, there's so many factors that go into what you're going to look like before and after. Again, like your age, your stage, your genetics, the elasticity of your skin. There's so many things that affect that. So we don't like to focus heavily on before and after photos for that purpose. Doc, would you agree?
I 100% agree. I think by and large, almost all observe some improvement in shape, but it's not something I think we should advertise. I think we can really hurt ourselves, our cause, because if it's part of the equation, aesthetic improvement, I think forget about
necessary, right?
I mean, it will hurt the patients themselves. Now, many of them contact us and we refer them to patients who were operated before, and they can share their pictures and they're available, but we don't like to put it on the website. I mean, it's just, I agree with Stephanie.
So next question concerning insurance. You said most lipedema surgeries in your office get approved. Please share what your practice is doing to get lipedema surgery approved by insurance.
Do you want me to answer that, Doc?
Go ahead.
Okay, so I covered some of this in my presentation as well. The way that we work to get you, the best chance of getting approval is by gathering as much information as we can to prove medical necessity. So again, like we talked about earlier with the to-do list that Doc will give each patient after their consultation, that to-do list can include, meeting with the lymphedema therapist and undergoing all conservative treatments if they have not already been optimized, meeting with your other physicians, letters of medical necessity from your other physicians, because it's very important too that Dr. Shapira isn't the only doctor in your team recommending that you have surgery. So, we like to gather as much evidence as possible before we submit to your insurance company in order to give you the best chance of getting approved.
Thank you. There are two questions.
Larry, she asked, I would say that of those that we submit, I would say probably between 75 and 80% get approved. The insurance company recognize that it's medically necessary. I would say close to 80%,
I think it's closer to 80.
closer to 80.
And that's the thing, it's not a quick process, like I said earlier too. It is something that can take, it could be as small, as short as a few weeks, but also many months. Again, that's something that we don't know until we get there, because each insurance company operates so differently. But it is something, to be prepared, I guess, for the long haul, because it's not something that, is usually done in a day or two. That's why, we like to be prepared. We want you to be prepared, in order to go forward and to get the best outcome.
Thank you. The next question is about, do you see many patients with problems in hips, lower back, feet?
Most, right?
Yeah. Many.
Stephanie,
Myself included.
yeah, Stephanie, you had 4 surgeries. What stage lipedema did you have? What areas were done in each surgery?
So again, I had stage 2 lipedema. I was diagnosed with stage 2 in 90% of my body. I had my legs done, my arms done, and my abdomen. So I had 4 procedures. The legs are always done in 2, so we break that up. So I had 2 procedures on my legs, 1 on my arms, and 1 on my abdomen.
And for how long did you have to wear compression garments?
So this is another loaded question that I love to answer. After every procedure, you will be in your compression 24 hours a day, 7 days a week for the first 14 days. The reason we do that is so, the compression really helps the skin retract to the underlying tissue that's been disturbed during the procedure. It will help with swelling. We do say to wear it, we even recommend that you shower with it on. We don't recommend that you take it off for 14 days. After the 14 days, if the patient is ready to do so, and this is something that you can kind of gauge by yourself as well, after the 14 days, it's very possible that you could go to, 12 hours on during the day and then 12 hours off in the evening. I personally wore mine for much longer than that, just because I felt much more secure with them on. As far as like skin, because sometimes we get some skin sensitivity afterwards, and I really felt for myself that wearing the compression longer was much better for me personally with my recovery. So I would say look forward to at least 2 weeks of it 24 hours a day for 2 weeks. And then after the 2 weeks, you could go down to 12 hours on, 12 hours off. We recommend to do that for at least 4 weeks following. So you could be looking at 6 weeks. And again, if the patient chooses to continue to wear compression because they feel better with it on, we leave that up to the patient at that time to, depending on what sort of swelling and other issues that they're still dealing with.
I think it's important also. It also depends to a great extent how much swelling you had prior to surgery, because that tells us how much stretching you had on your lymphatic vessels prior to surgery. Because if they were abnormal prior to surgery, there's a good chance it will take them a while to recover. And sometimes it's very difficult to predict. Sometimes maybe they will not make full recovery. If you're stage 4, they may not make recovery. So really have to gauge it to the patients. I highly recommend, and everybody gets it now, they put the short stretch wraps after surgery. That's nicely tolerated, and they really feel much better because it really helps to push the fluid to prevent accumulation of fluid in the legs.
Right.
For the garments, the question, part of the question here is whether or not the garments were expensive.
I believe the garment that we recommend one from a company called Morena. I believe it's around $170 maybe. It's less than $200. I know that. I don't know off the top of my head the exact amount, but we do for all of our patients have a discount code where, you know, as a patient of ours, you would get 15% off any garment that you purchase from the company. So that helps too.
Thank you. What kind of diet, Dr. Shapira, do you recommend for patients to follow?
Are you ready, Doc? This is where we disagree.
Well, I like a keto diet. I think keto diet, you really can enjoy food. And once you go through the initial period when your body get used to that, you eat less, you eat well, you really can enjoy food. My wife preparing great keto meals, and personally, I love it. But it's not a personal story. I really think, now it'll sound funny, but except Stephanie, all my patients love keto diet. I'm just joking. No, but the majority of the patients really like it, and they feel, and if they stop the keto, they really feel worse and they go back to it. But it's not a one size fit all, and people are different. I mean, if you have gallbladder disease, maybe keto will not be good for you. If you had a Roux-en-Y, a gastric bypass, I'm not sure that's ideal diet. In other words, you really have to find the diet, but the key is low diet that will cause minimal inflammation.
I agree with that.
That's the key.
So I personally don't like the keto diet. I don't think that it works for everyone. I'm living proof of that. This is actually part of the reason why I started the process of getting certified in functional nutrition. Really because I don't feel like, especially even with lipedema, I don't think that there's one diet that cures everything and works for everything. So my goal, you know, is hopefully by the end of the summer, I'll have my certification to start coaching our patients on their, you know, nutrition, because I really don't think that, like I said, keto doesn't work for everyone. Some people love it, some people don't. I happen not to. I primarily like to focus on whole foods, nothing processed, foods that are low in inflammation, getting lots of water. So I take a slightly different approach to that for myself, but you know, it really is, each patient needs to find what works for them, I think, is really the best way to go.
Agree. You see, Stephanie, we agreed about something.
And if you haven't noticed, Doc and I put the fun in dysfunction.
Dr. Shapiro, we cannot see you anymore, but anyway,
We
the
lost
next
him.
here is once you have a hip
Lynn?
replacement. What? Yeah.
Can
There
you
you
see
are,
me
you're
now?
back. Yes, you're good. Stop touching your computer.
Nothing funny. I'm good.
So
Go ahead, Larry.
Once you had a hip replacement, you cannot use a vibration plate anymore. Anything to substitute?
Swimming?
Good point.
Yeah. Yeah, but swimming will not do this. The vibration
Right, but I'm
is
right.
different. Vibration is really hard because by losing your gravity for half a second, when vibration, the fluid in your lymphatics moves up, because when you go down, it goes through the valves. I don't know if I explained it well. Swimming is great, any exercise, but I don't think it will substitute for vibration.
I don't really think there is a substitute for vibration. I just know that swimming, you know, works well to move fluid because the water in the swimming pool actually acts as a natural compression. And, you know, moving the body while you're floating and being compressed also helps pump your lymphatic system and get a lot of that fluid moving.
Yeah.
So one question here is, Dr. Shapira, do your patients need to stay overnight in the hospital?
they don't stay in hospital. They usually, no, they come in the morning, we do the procedure, we finish the procedure, we'll give them a good keto salad. No, I'm joking, just a good salad. They drink, they eat. We dress them, we put the compression. They step down from the table. And usually within 2 hours, maybe 2.5 hours, they just walk out with whoever they came with. And if they came from far, they usually stay in a hotel for a night or two. If they live nearby within 2 hours, usually also they prefer to stay overnight in a hotel. But especially if they fly, then they stay maybe 2 or 3 nights. And I see them after that. At 9 o'clock, at 8:45 sharp, they have to call me to talk to me. Every night we need to talk to see, make sure they're okay. But we're not, I mean, everything done in the office.
It's done in the office. I think, yeah, that's the, you know, we don't operate, Dr. Shapira doesn't operate in a hospital, so all of your procedures are done in our office.
The nitrous oxide really help us to cut back on the local anesthetic medication that we give, local anesthesia. So if you use less, the recovery is faster. And so they really, lately, I think after 2, maybe 3 hours, they sit in the office, they chat, they relax, they can just walk, and they're doing fine.
So one question here is, what if the patient has a lot of loose skin after surgery, after water jet surgery?
Good question. You could ask me a more difficult question if they have a lot of loose skin before surgery, what they're going to do. So thank you for asking this question, because, and that's my personal view, I don't want to use any heat energy during the liposuction, because for me, any heat that you try to tighten the skin with, doesn't matter what method, laser, Vaser, ultrasound, whatever you're going to use, whatever generates heats can also destroy lymphatics. And remember, the lymphatics in lipedema, even in stage 2, they're not normal, they're stretched, they're more vulnerable. So I don't like to use any heat energy during the procedure. So if then there's significant skin retraction subsequent to the procedure, I guess the water jet, just the jet itself, the mechanical simulation of the jet stimulates some retraction of the skin. So you will see improvement in the sagginess of the skin after that. And that improvement can last a good year, year and a half, because that's how long it takes you to build collagen. If it's still you are not happy, I have no objection at that point. After the lymphatic recovered, after everything, you are healed. If you go for surgery to remove the brachioplasty, to remove some of the skin, or to go then for a heat-based skin tightening, at that point, I think it's much less risky than if you combine it with a procedure that aims to remove the fat while preserving the lymphatics.
So the next question is for out-of-town patients. How long do you like them to stay in the area after a procedure?
What kind of patients? I'm sorry?
Out of town.
Out of town? Well, usually experience show that those are coming from far away. Usually they stay, I would say, what, Stephanie, 2 nights? Usually
3 to 4 days, maybe.
Yeah, because for the first procedure, they don't know how they're going to respond, they're going to feel, better to feel weight, all that. Usually, once I experience, they're feel much more ready to leave after maybe 1 or 2 nights. It's quite personal, and if we do it over the, like on Thursday, for example, then they stay for the weekend and go on Sunday evening or Monday morning. But that's usually what's happening.
Which is better, water jet first or fixing the knee if the internal part of the knee is bone on bone due to lipolymphedema?
What is better, what? To do the knee?
I think the question is to do liposuction first or to have a knee replacement. That's how I'm understanding the question.
Yeah.
Okay, I can answer this way. First of all, I had several patients that required knee replacement. They met the criteria, bone on bone, etc., etc., but no one was willing to operate on them because they said that the risk of skin infection in the healing, if you go through this very large pocket of fat overriding the knee area, they refused to do that. So they had to go through liposuction first. I probably recommend liposuction first. For what comes to my mind, A, maybe you'll not need knee replacement. B, if you have foreign body and God forbid you have infection during the liposuction, which is rare, but it happened. It happens. If you get it, you don't want the foreign body, i.e. the artificial knee, to get infected, contaminated. So that's another reason to do it, the liposuction first. And 3, the reason that it's just technically for the orthopedic surgeon, excuse me, I think they prefer to do it, but they don't have to go through all this thick fat layer.
Thank you. One question here is concerning insurance. In some cases during lipoedema, you are also suffering from an enlarged heart. Will this have an influence when you're having this disease? Will this have an influence as an argument when addressing insurance?
Not when addressing the insurance. I think when we talk in the consultation, then we collect the information. We see the echocardiogram of the heart. I have to see how thick is the left ventricle, how big is the left ventricle volume. I'm going back to my prior career now. How you respond to exercise, to stress, what medications you're on. And probably have to talk with your cardiologist or with your primary care physician and see. But I will not deny it, because by enable you to, what's one of the important treatments for heart problems? Ambulation, walking, exercise, right? So if this poor patient cannot do that, it's terrible. So if we can help carefully with a good judgment how to improve her mobility, I think that's great. It'll be good for the heart.
Thank you. Then question here, what if you have Dercum's disease? Will water jet cause trauma to the body? In Dercum's, trauma causes the body to grow more lipomass?
Well, Stephanie has Dercum disease. People say Dercum disease is like spectrum. There's a lot about Dercum disease. I don't understand something about Dercum disease that I do understand. But I know that with the liposuction, with the jet, we can remove the nodules, the tender nodules from the area that we perform the liposuction. I think I know that. Since we don't know what exactly the etiology of Dercum's disease, I don't know what the chance that it will come back. Some people say that Dr. Stutz told me that people with Dercum's disease should be prepared that they have some of the Dercum's disease may come back. So I don't think that the procedure is basically the same. It's the same because the nodules of the fat are within the fat that between the skin and the muscle. So you remove the abnormal fat. Hopefully you remove all of the Dercum's disease and minimize the chance to reoccur. Do you have anything, Stephanie?
I just wanted to add, even when I had met with Dr. Herbst for when she diagnosed me, there was some talk that she explained to me at that time that she believes, and I don't know, maybe she's changed her opinion since, but when I spoke with her, she told me that she believes that diffuse Dercum's disease, which is not necessarily like large lipomas, they're more like it's smaller, more spread out over the body, is kind of on the spectrum of lipedema. So I don't think we really know the answer to, is it diffuse Dercum's disease or is it lipedema? So from what, like Doc said, the treatment is the same. We just have to be mindful of the fact that there is a chance for some recurrence with the Dercum's crossover, for sure.
Thank you. Another question is, would acoustic wave therapy help?
A what?
Would acoustic wave therapy help?
Acoustic?
Acoustic wave.
Yeah, I don't know what that is.
There's an acoustic wave that you can use for skin tightening, for example. Is that something that also helps against lipedema? Probably not, but this is a question that comes up here.
No idea. No idea.
And the last question I got here is, please tell us about your consultation process through telemedicine.
Stephanie?
Okay, so the nice thing about telemedicine is now, thankfully, our insurance companies will pay for it thanks to COVID. So that's good. That's hopeful. And I want to say too, Dr. Shapira, his examinations are so thorough. And I think, obviously coming to the office, for an in-person consultation is always preferred. But I do think that Doc can do a very, very thorough exam through telemedicine, almost just as well as he could do in person. So they're not really treated any differently. If you wanted to become a patient, you could just reach out to me. I can send you the new patient packet for you to send back. And once we do that, we, schedule the appointment. But there's not too much of a difference in the appointments other than, you're in the office or you're not. Dr. Shapira does spend, I want to say, what, Doc, like maybe 2 hours for each consultation, on average 2 hours. So plan, to be with him for a while. And you want to be somewhere preferably quiet and alone, so that, if he wants you to show him, certain parts of your legs, you're in a place where you can do that. But they've actually, I think the appointments have been working out quite nicely.
Yeah, they work very nice. We have a very good video system that really very, very good audio and visual. Obviously, I cannot put a stethoscope to listen to your heart or to your lungs, and something I cannot feel underneath the skin, the nodule, whether you have nodule and all that. But I use your hands to examine your body. So I say, look here, press here, does that hurt, or that hurts less, etc., etc. Press here, do you have any pitting, etc., etc. The good thing about it that you really can start the process after a remote, a conference, because we can start to collect the material, we can advise you whom to see, what kind of compressions you need, etc., etc. So hopefully the COVID-19 will be over. We'll be already in the middle of the process or more towards the end. So really should not hold us.
Thank you. Those are the questions so far. I think those are either answered during the presentation or during our question and answering. If not, we will review all your questions that you sent us and see if there is one that we missed, and we'll answer that individually. What left is, once again, thank you, Dr. Shapira, thank you, Stephanie, for your excellent presentations and your really, really helpful information. What left is also to thank all of you for attending the webinar. If you'd like to get more information, please refer directly to Dr. Shapira, to Stephanie, or to our website, lifewithlipedema.com, that you can see here on your screen, just in case if you need some more information or looking for a physician near you when you're a little bit more far away from Delaware. So, yeah, a nice day to all of you. We hope to welcome you again for one of our next webinars. And once again, Stephanie, Dr. Shapira, thanks a lot.